everyone. Welcome. We're glad that you're here and we appreciate you coming to spend some time with us this evening. If you're a return viewer, thanks for coming back. And if you're new to the Parents Helping Parents Connections California screen, thank you for coming. So, what we need to know about transition to adult medical care, medical issues in autism through the lifespan. If that's where you want to be, you are at the right place. Dr. David Traver or Traver. I'm sorry, I didn't ask how to pronounce your name, but you could tell everybody how you do that. Has been serving the special needs community for over 25 years. He's a board-certified pediatrician and a fellow of the American Academy of Pediatrics, and received his MD from Boston University of Medicine and completed his residency in pediatrics at what is currently Boston Medical Center. After finishing his postgraduate training at Stanford's Division of Child and Adolescent Psychiatry, he started a private practice focusing on autism spectrum disorders. He currently employs a combination of traditional, integrative, and cutting-edge researched approaches in the testing and treatment of autism and other neurodevelopmental conditions. While tonight's presentation discusses the transition from pediatric to adult medical care in general terms, you may see because Dr. Traver is an expert in autism, the presentation will delve into healthcare transition challenges people with autism may face, but rest assured, the point being made is that all people with disabilities face challenges, and we'll be covering them. And again, I will be dropping links into the chat. They will be sent with you in with the slides tomorrow in an email. So without further ado, I'm going to turn it over. So thank you so much for coming. And thank you, Dr. Traver.
Righty, let's see. Hope everyone can see that. Are you able to see?
We are good.
Good. All right. Well, first of all, I'd like to thank PHP and Connections California for having me. I'm very grateful to be here. It's a privilege to serve not only the individuals who have the challenges, but the families, and it's not lost on anybody attending tonight how pervasive the challenges can be when we are discussing this topic. So hopefully it'll also be evident that as I think Lisa mentioned, what we're going to discuss here applies not only to autism, but in many ways to other conditions. And without going into unnecessary science in the very beginning, it's been very educational for all of us in the medical community to realize that autism shares different metabolic signatures and such with other conditions that are not considered necessarily autistic, but have similar genetic underpinnings. And most of these are multi or polygenic, but we can talk more about that down the road. Again, this is the medical issues in autism through the lifespan. And one thing I was sharing a little bit earlier with Alyssa is that, and you can call me whatever, David Traver is my name, but you call me David, Dr. Dave, whatever you would like, I'm fine. What I will share is that the idea of transition is a huge one. And of course, it's huge for a lot of different reasons, the emotional component, the financial aspect. But unless the individuals that are involved with this are aware of the medical challenges that the individual is facing or may face, the transition tends to not be as optimal as it could. So it's not just about logistics, going to a person, getting someplace nearby, or somebody who will see your loved one. It really has to do with without trying to make everyone into a doctor or a medical professional, the understanding that there are certain conditions of which, if the team is made aware, the transition can go much better, and you'll find the best person for the individual, the person you care for. Hope that makes some sense. So really today, I'm going to try to leave a good amount of time for Q&A. I think the gold is always in the interaction, the questions that people pose. Hopefully it'll make it relevant for people, not just theoretical. That's not my goal. The two objectives, the goals I have today, are to provide an awareness of the diverse number of medical and health-related conditions that parents, caregivers, and even providers may not be aware of, but need to know about. And then in that light, offer practical measures and resources to support the healthcare transition into adult-centered care. Okay. See if I can. There we go. So this is a fairly sobering slide. And again, I'm just using autism for the model. Over the next decade, roughly around a million teens will enter adulthood and age out of school-based services. 50,000 individuals with spectrum disorders are turning 18 every year. That number, of, as you might guess, continues to rise. 50% have a co-occurring condition. And in fact, even more than that, 60% of all 15 to 17-year-old boys and girls have at least, with autism, have at least two conditions in addition to the spectrum diagnosis. Some of these co-occurring conditions include intellectual disability. Clearly, that's not true for everybody, but mental health conditions in general can be much more observed. ADHD, and of course, we know that up to 1 out of every 3 children can have epilepsy with autism. That's a staggering statistic when you compare it to the number that are seen in neurotypical children. Better healthcare transition and more comprehensive healthcare in young adulthood has potential to improve the health outcomes of people with spectrum disorders. That makes sense, and the power of that is seen when you actually do it right and you get the people involved. Transition, if you need a definition, this is actually not mine, it's a real definition, is excuse me, process where HCT, healthcare transition, moves the individual from a child family-centered model of healthcare, certainly medical care, to an adult or patient-centered model where they either become more autonomous or the issues that they address are a pivot. And that is done with or without transferring to a new clinician. That last part of it is very important to realize, because when you transfer to a new doctor, as you already could guess, it becomes a whole new ball of wax for the person to learn who your loved one is, and vice versa. But it obviously involves planning, transfer logistics, and most importantly, the integration into the adult-centered care. We'll talk about how that can be facilitated in just a little bit. This is basically what I want to do. Is I want to share with you that tonight, I think I put this up as more of a skeleton. We're going to look at logistical hurdles. We're going to look at the diagnostic challenges that face not only the doctor, but of course the parents, especially for individuals who are nonverbal or have limited communication. We're also going to look at the medical conditions that these individuals face. Some of you may know about this, others may surprise you. And then I'm going to, go right into the resources, what we can do to practicalize the awareness of these medical conditions to, again, grease the wheels for healthcare transition. I hope that makes sense. The logistical challenges in autism, and you can read off obviously what this is saying, but it really starts with what is unfortunately can be a rude awakening, when the family takes the person that they care for to somebody who's a medical professional. It's not surprising to find the encounter to be less than fulfilling. The provider often does not have training in autism. In fact, I can tell you, certainly as a doctor, I got no training in it. Everything that I received was after, based on my focus in this area. There's often a lack of time. It's no surprise to most of you on this webinar that the average amount of time you get for an outpatient appointment is somewhere around 15 minutes, give or take some, but it's certainly not exorbitant. And usually it's the person's looking at a computer as you're talking to them. It's quite disconnecting. And of course, as you would guess, there's a lack of reimbursement. Again, a common realization that's becoming even more well known. As time goes on, reimbursement continues to be harder to come by for individuals with conditions that really deserve that kind of support. A very hot lightning rod is the experience that individuals face in the emergency room. This is not someplace you want to be, but this is often where people go. It's the final resting place because people often don't have primary care. And what people may not know on this meeting tonight is that after a person leaves an emergency room, the job of an ER doctor, and I'm not trying to be crass or unnecessarily disparaging. The job of an ER doctor is to get the patient out of the ER. The job of the doctor is to stabilize them in a sense that will get them away from the ER, and then have that individual followed up by their primary care doctor, nurse practitioner, whoever. But as you can see, a lot of individuals don't have a primary care physician that is available to meet the person after they've had an acute incident. Oftentimes the encounters in the ER are very suboptimal. We all can probably imagine some of the nightmarish experiences that individuals who are nonverbal have in this setting. And it does not help that there's no doctor that the ER doctor can call to find out a little background. So this makes it doubly difficult. And then, of course, insurance coverage in of its own right, low reimbursement, no incentive for doctors to accept patients who cannot pay, or they're not going to get much back from. The waiting times can last literally not only months, actually years sometimes, given the subspecialty. And the key is for, again, the medical establishment that you are working with or you encounter to be aware and informed of the medical and mental condition of the individual that you are trying to get help for. We're going to go into the diagnostic on healthcare transition challenges. And this is important not just for autism, but anyone who has a nonverbal individual of any kind of quote unquote diagnosis. And the key word in red here is atypical. A lot of individuals with autism do not present in a manner that is expected. And it is very difficult for physicians in pressured settings to think outside the box. But let me give you an example. So a term that we all have come to understand is SIB, which is self-injurious behavior. But really, it's now become increasingly evident that when an individual has self-injurious behavior, I've been doing this now for 26 years. I never regard SIB as something that is hardwired. There is a reason the individual is having that behavior. It is unjust, and it is not professional to attribute that to quote unquote being, oh, that's the way they are. They're autistic. There's no room for that. That has no place in medical care. These individuals are usually in pain in some way, shape, or form, and this needs to be exhausted, and the search needs to be done. A negative search can bring no satisfaction. So I want you to hear me on this one. Dental caries, individuals can be hitting their head. They can be oftentimes biting themselves if they tap their chest, or they are hitting their head. Often this has been found to be correlated with gastroesophageal reflux disorder. And the burning, of course, some of us have had that. It's extremely painful. It's very unpleasant. But they actually do not, point to that exact area. And in some cases, they'll bite themselves. So when an individual is biting themselves, this is pain in the body until proven otherwise. Posturing and pressure, again, some of you may already know this, but this can come from intestinal spasming, inflammatory change, frankly, stool retention, and beyond the idea of quote unquote constipation, you can actually get obstruction. This needs to be considered first and foremost in any patient that comes in distress with a spectrum disorder. Appendicitis has been observed not uncommonly, and so I trust nothing. When I see my patients, I want them to know we're going to continue focusing on what it takes to get them the answer they need. And that may take imaging. It may take more than just a nice, good physical exam. I understand how difficult it is. This takes time, and you have to be committed to it. If sudden arms flailings, there's a medical term for this, like hemiballismus, but this can be actually not, this is not a person acting weird. This is somebody who has often a loss or alteration of what we call proprioception. If a person can acquire language, and this is something that I speak of from experience, we find that individuals often have this flailing because they cannot control it, and they have a loss of the ability to understand where their extremities are in space. I know that may not sound very common, and it's not, but this is, you can imagine maybe you've fallen asleep on your arm. You understand what I'm talking about here. It's very hard. It's not a comfortable feeling. You have to literally lift your arm up with your other hand. This is akin to what these individuals can experience. Do not ever accept these kinds of behaviors as that's just okay, they're autistic. Again, that is a disparagement of the real situation. And finally, skin scratching and picking. These are paresthesias, a fancy medical word for altered sensation. And individuals who have had this kind of behavior have gone on after they've been able to communicate to say, you didn't understand when I was picking my skin, when I was scratching my skin, when I was in this distressed state. I felt like my skin was on fire. I felt like there were ants underneath my skin. I could not stop. So this is for everyone to hear. I'm sorry if you've heard it before. I want to make sure that we get the message out that this has to be something that you can certainly, this will be available after my presentation, but I want you to be able to communicate this to people involved in the person who you care for in their life. So I hope that makes sense. I'm trying to go fast enough, so there's Q&A. Um, other awareness issues, I've talked about GI issues. Here we also have to think about medication management. Is the person able to swallow? Sometimes doctors are not aware. There's always, in my world, the compounding pharmacy, and we have to get creative, and we have to find routes of delivery to be able to offer these individuals the successful administration of medication they need. I will find a way to get this in, and I will often call multiple pharmacies. Good luck. Hopefully you get a real person answering the phone, but I will try to get them to help me understand what they can do to help my patients. So obviously self-medication is a little bit on the edge. You don't, hopefully not, they're not doing that, but you would like to be able to make sure that those in charge of medication are not overlooking issues that need to be attended to. Sleep disorders, obstructive sleep apnea. I'm sure we've heard of CPAP by now, which is a common and very uncomfortable remedy for this. But anybody who has disrupted sleep, who doesn't nowadays, but any of the individuals that we're talking about tonight have to be kept under the looking glass for a possible sleep disorder. And in that regard, one of the things I'm going to punch in here real quickly, people, is that if a person has a sleep disorder, they should have their iron checked, their ferritin, because low ferritin and low folates bode poorly for sleep. We can go talk about that later if we need to, but that's a quick pearl. Dental care or poor access, please make sure that the individual that you're caring for has appropriate dental care. I know how difficult it can be to get these individuals going. We can talk more about this for options. I work every option I can, but this is extremely important. And of course, you could guess that when this is happening, one person, I'm sorry to get graphic here, I'm going to say it because people need to know this is happening. One person had such pain from their teeth, they actually gouged out their eye. And so we cannot tolerate that. That has to be prevented at all costs. But this is real pain. They're not bad people. I just can't continue to emphasize this enough. Next, I'm going to talk about medical conditions of which we need to be aware of regarding neurological issues. I want to make sure people know that seizures are a real threat to this population, especially those at nighttime. Oftentimes in the daytime, if a person has a seizure, you might be able to pick it up, and there are different presentations. We understand that, but one thing I do want to emphasize is that there are things like Landau-Kleffner syndrome and ESES and some of these medical terms I won't really go into right now, but they actually have to do with the onset of seizures that are not readily seen, but with which come loss of cognitive ability or language. So if the person we're talking about here has that, you really have to be aware that not everyone's going to have a seizure. I want to make sure you understand that, please. So let's not run out but I want to make sure this is a conversation, and the person with whom you're speaking regarding the care is made aware. We're not going to just go quietly. We're going to make sure this individual has the kind of surveillance. And by the way, I'm just going to put this in as a quick plug again, please. A half-hour EEG is unacceptable. We can talk about that down the road. I do not accept that, and I push hard on my patients with the neurologist to do more than that. Again, there's just too much tonight to go into regarding that. But seizures, tardive dyskinesia from medication, a permanent side effect. We must do everything we can to stop that. When it comes to transitions, making sure that hearing and vision are checked. Developmental optometrists can often be very helpful with some of those bullet points regarding vision. And obesity is obviously a real issue, especially with those who, for whom eating becomes the go-to soothing pastime when it comes to dealing with anxiety. We'll have to talk about that some another time. Here on this slide, I'm going to talk about how basically awareness improves the screening and care for and outcomes, especially not just for metabolic issues like diabetes, which goes unsaid, but especially for women. Women tend to be underserved. They tend to be ignored in the medical arena because women are women. That's the idea. And again, this is inappropriate. But what has been found with some of these studies that you can reference on your own is that in this population of those who are intellectually disabled, not just autism, but special needs populations with different conditions, the screening for breast issues, cervical cancer is underutilized. The idea of women having very difficult periods. This isn't just a little pain. This is where periods can become crippling. And that has to do with inflammatory change. Again, I won't go into the details, but inflammation is a strong undertow in the pathophysiology of these individuals, and that has to be kept in mind always, always, always. Obviously, menstrual irregularity is an inflammatory related issue that I think goes unsaid, but please be aware of that so that appropriate concern and medication can be provided if needed, as well as treatments for other issues. Not only do we find the issues for neurologic and gynecologic issues being sometimes met at a subthreshold level, we find that mental health issues are rife. Now, let me make sure everyone understands one thing. Autism is a body-wide, system-wide set of conditions, which the boundaries of which remain to be established. I can go into my definition at some other time, but it is in a very amorphous set of conditions, and no two people are alike. I know you've heard the phrase, when you've seen one person with autism, you've seen one person with autism. But I want to make sure you understand that the mental health conditions as you transition are absolutely critical to be kept in mind and to be pursued. Just because somebody is autistic does not mean that they have anxiety or they have depression or any of the things listed in the bullet points, but it also means that you cannot assume that they don't. So especially, we know what we went through in the globe a few years ago, and the isolation is real. And the isolation that these individuals, you may have seen the Time magazine that came out a month ago. It was on the newsstands. It was more of a specialty issue, and in it is an article talking about the extreme loneliness in autism. And if any of us have been lonely, it does not touch what these individuals feel. So I'm asking you to make sure that this is brought up with your medical team. The anxiety and depression that can sometimes co-occur are also issues that demand recognition and also treatment. And by the way, I do not, as a doctor, just believe in medication. I also work with natural treatments. They are my first line therapy. And not because I like being a natural doctor per se, although I guess I might as well say that now. But I do believe that there are less side effects. They are equally as efficacious if given per the individual. And I think that they have less side effects. So in that regard, looking into these conditions should not intimidate us. They should be evaluated so that the individual can receive the kind of support they need. And of course, stress and dementia are part of that. This is the first of two studies that I wanted to basically look at that came out a little less than 2 years ago. And this study really expanded our understanding of what individuals with autism and as well other disorders can experience. And this study by Liu looked at older adults, and they spanned if you will, the horizon of 39 different conditions, 5 different types of injuries, and they calculated a cumulative index and a hazard ratio. For those of us who did not like epidemiology or did not ever take it, I'm in that category, by the way. I didn't like it. Cumulative incidence basically is the risk of a disease or an event over a short or longer period of time. So what's the risk that they'll get this? And then a hazard ratio, HR, really is somebody in the group with a higher hazard will reach the endpoint first. And they looked at whether intellectual disability or sex influenced this at all. So in this regard, they found that medical conditions, this is probably no surprise to most people, were higher for autistic than for non-autistic individuals. And this was the case for 15 different conditions. The awareness of these conditions, I'm asking you to go to this and write these down later, will help the one you love, because there'll be something for which or about which even now, before something happens, preventative measures can be made or awareness can be gained as through testing, etc. Heart failure, 89% increase. Cystitis, twice as high. Glucose, by the way, cystitis doesn't just mean in bladder infection. It can be inflammation, including interstitial cystitis as well. Glucose dysregulation, a lot of individuals have metabolic challenge. There, it's almost 3 times the amount of a non-autistic individual. Iron deficiency anemia, IDA, over 3 times the prevalence. And others, I did not go into it, but esophageal issues, stomach issues, and inability to swallow. Patients actually try to swallow. They're not being bad, and they cannot do it. It has to do with motor control, nerve input, but these are real issues that doctors may not be aware of, and the kind of medication they provide should reflect their understanding. Metabolic, type 2 diabetes, huge, and of course, believe it or not, even skeletal issues. And one thing I want to help you understand, skeletal issues are a reflection of inflammation. Skeletal issues are important because, as some of you may know, when women, as a young girl, most women, as females, accrue their calcium density in the early years of their life. As menstruation is going on, right? It's not like you wait till you're 60 years old and then take a pound of calcium every day. It's not the same. It doesn't work. So what we find is in this population is that a number of these individuals actually have very thin bones, much like people who don't take that calcium in the early years of their life. Excuse me. And so we can see bone thinning. We can see loss of bone density in a premature manner. Arthritis, again, obviously inflammatory, and spinal issues reflect this as well. The highest cumulative index was for bodily injuries. And this, of course, is sad and unfortunately not surprising. The rate of self-harm was 7 times that of non-autistic individuals. Poisoning was almost 5 times. And I don't necessarily believe that all of this was deliberate. Falls, physical injury, obviously the magnitude of these challenges eclipses that of the ones we saw earlier. Not to say the others are unimportant, but individuals like this deserve protection and proactive forethought, so that everything can be done to mitigate the unnecessary harm that ends up happening to these individuals. I'm going to move forward. And by the way, the risks were increased regardless of the intellectual disability or sex. I think that surprised them. They thought it was going to be based on ID, and that was not the case, or more male-oriented, not the case. This has to do with the second study as we kind of round the final lap, and that has to do with something called CPHC, chronic physical health conditions. And there are higher rates of these chronic physical health conditions, CPHC, across the entire body, and are multisystemic. Organs are involved, and these individuals are more likely to have complex health needs, much more than earlier thought. This is very important because 60 different conditions were assessed across 9 organ systems. And when someone thinks of autism or even Down syndrome or somebody with intellectual disability, they don't think about gastrointestinal necessarily. I'm talking about doctors and endocrinologic, vitamin D. Most of my patients have low vitamin D. Vitamin D is a neurohormone. It can improve the neural functioning. I push vitamin D very strongly, not to give them kidney stones, but to make sure that they are not ignored and that appropriate surveillance is given. Surveillance is the key word here. 9 organ systems: rheumatologic, neurologic, obviously, ophthalmologic, ocular, kidney, liver, renal, hepatic, ear, nose, and throat, hematologic, and dermatologic. In fact, again, folks, this is a body-wide, system-wide set of conditions. And higher rates of 33 conditions were noted compared to those individuals in study that were not autistic. Celiac disease, gallbladder disease, endometriosis, syncope, which is fainting, vertigo, the spinning room effect, urinary incontinence, eczema, and again, iron deficiency anemia. By the way, just a real quick pearl, please. Anyone who has a ferritin of 30 or less, even if it's in the range of the test, deserves iron. And this is important for cognition. It's important to overcome lead poisoning. I want iron pushed hard on my patients. I understand about constipation. We can talk about that, but iron is a friend to most of these individuals, and it can be monitored as I typically do. Next, the study by Ward was very interesting because it showed a unique connection of what we call Ehlers-Danlos syndrome, which basically is a connective tissue condition where joints are hypermobile. There's genetic underpinnings for loose connective tissue, faulty connective tissue. The joints can become dislocated. It's painful. The skin becomes stretchy, the rubber man kind of thing. They easily bruised. It's not a fun thing. It's not a circus thing. This is a very difficult condition with which to live in. The different types, by the way. But you can have organ prolapse where the organs internally can come out of their sheath, hernias, obviously in the inguinal area. And this is something very difficult. And they found in a Swedish study in 2016, 9 years ago, believe it or not, that EDS was 7.5 times more likely to have an autism diagnosis. So people who are diagnosed with EDS have a 7.5 times likelihood of being autistic. And as well, conversely, those over half of the autistic individuals that had hypermobility have had EDS. So this is something that is important to note. If you have a female in your group, please be aware of that. It doesn't mean males can't have it, but especially for females, please take note of this. CSS, central sensitivity syndromes. A lot of you have heard of irritable bowel syndrome, temporal mandibular joint (TMJ) in your jaw. All of these, migraines, ear ringing, chronic fatigue syndrome, fibromyalgia, pelvic pain, restless leg syndrome. I know it's not on there, but it's part of it. POTS. These are all thought to be a cascade results of something called central sensitivity syndrome, which is where there's a heightened ability of the nervous system to respond to stimuli that's abnormal. And so it upregulates the thermostat in a way so that there's excitation at a level that should not occur. And the combination of conditions found in this population differed between those who are autistic and, of course, those who are not. And as you might guess, very few of these labels or these diagnoses here go away quickly. In order to effectively deal with these, typically you have to go backwards and go to more of a root issue rather than treating the surface. Very difficult. Some of the proactive measures, let's get right to it, please. A lot of work needs to be done to assure quality medical care for aging adults with autism. Primarily, this is no surprise to most of you, the family takes the load, but let's start there and we can ripple out. I believe in professional advocacy. I try to do as much of that as I can, but the proactive role is really by those who know the person the best because they are in the best position to be able to inform others. So increasing awareness, regular checkups, and I plead with my families to, I know that life is overwhelming. I know that just surviving is the gold medal, but I want you please to keep the best you can. Please try not to wait until a medical issue or problem becomes manifest. Please make sure that you know that home visits are possible. Home visits, even by nurses or blood drawers. We'll get to that in a second. So before the transition begins, please select somebody, if you could, who doesn't have to be a new human being in their life. Somebody with family medicine, somebody who has a pediatric / internal medicine background. They have those individuals. So the person knows them from the bottom up. Some of this is already in the medical system, you understand, whether it's someone who has congenital heart disease. Guess who ends up taking care of that person when they turn 40 or 50? The pediatrician, who understands congenital heart disease better than an adult doctor, who deals with things like heart attacks, sickle cell anemia, cystic fibrosis. This is not a new model. We don't need to reinvent the wheel. So build on this model, become aware that it exists, and expect the system to be able to create a dialogue with you on this. Choose someone with a functional medicine background, which is basically, in addition to allopathic medicine, Western medicine that I initially received, I've spent years now trying to learn different testing and ways of getting underneath the issues rather than just treating the symptoms. I hope that makes sense. One of the best things you can do is, of course, invoke the help of the primary care provider, and make sure that they are kept in tune. Don't just give them bad news. Let them know that your loved one or the one you care for is doing well. And then making sure that you don't have to have all these people on the screen here as part of your team, but hopefully you'll have some of them if needed. And so there are psychiatrists that are better trained in some of these issues. There are psychiatrists that are trained in PANS and PANDAS. I won't go into that right now, but some of you may know what that is. And infectious related mental health changes. There are neurologists who are more trained in autism. The average neurologist, it's very difficult to find a good neurologist for people with special needs. There's a lot of cookie cuttering out there. I'm not trying to demean my profession, but I want you to know that you should try to find somebody who has that, and even if they're not with your immediate area, it's worth being on a Zoom with them. MAPS training, I'm a MAPS doctor. These are doctors who are trained in things like some of the areas that we've talked about. Autism Research Institute in San Diego is a wonderful resource. We'll look at them in just a second. And the Neuroimmune Foundation is wonderful for PANS and PANDAS, because PANS and PANDAS, the infection-related mental health changes dealing with OCD and regression of behavior, etc., has now found an interface, as you would guess, with autism spectrum disorders. Proactive measures include knowing that you can acquire home visits, blood draws at home. You can actually have your loved ones stay right there. They can come, they can visit. They don't have to do something right then. They can come back, and they can be somebody with whom the person who you're trying to offer care for can become familiar. I often do that. I go out to the parking lot and sit in the car. I walk the parking lot with my patients. Meet the patient where they're at. Don't try to fit them into your box. I don't know if that makes any sense. Initiate building a relationship with a contact in your hospital. This can be facilitated through your primary care provider. If you don't know what to do, talk to them about this. It's worth it. Build a relationship with members. I know you may think, well, why do I need to build a relationship with the receptionist? Because that's the first person you're going to encounter. And rather than just trying to get to know somebody so you can get what you want, these people actually have hard jobs. And it's hard to be a receptionist. I don't know if any of you are, but not everyone's happy. So medical assistants, nurses, MDs, this is the team. And I try to do my best as a doctor and as a patient to be able to establish a friendly rapport. The transition resources, and then this is our final 1 or 2 slides. This is the best resource I found is something called gottransition.org. I hope some of you already know about that. This is a family toolkit that really is very comprehensive, and it really goes through all the different nuances of transitioning somebody who's more of a pediatric patient to adult care. You can see the website there. It's an excellent resource, not just for you, but for other people as well who are trying to provide the care. It should be something that you can give to somebody and say, hi, I want you to take a look at this. I'll call you later, not in 5 minutes, but I'd like to be able to discuss care for my loved one using this platform. There are a variety of tools, and this has been copied and it has been modified by different institutions. You're going to see that in just a second. And you can reproduce it and customize it for your own situation. That's really nice. It's not a cookie cutter template. And many organizations are using this. In fact, as we go right to it, these are some of the different, I'm not going to read these out loud. I think you can read. These are some of the different places that have these kinds of resources available for people who are just beginning. Obviously, you don't have to limit yourself to one. Vanderbilt Kennedy Center is an excellent one out of the bottom here. Let me show you right there. I really like that one as well. There's the Autism Research Institute. I told you I'd reference that. And then I'm going to share one other thing. This will be made available to you. You don't need to memorize this. That'd be ridiculous. But Harvard has gotten into the act, of course, and they have a toolkit. So toolkits are kind of nice because they're right hands-on, boom, right there. But you might want to see some of these other resources that give you a deeper dive. And you can discuss this with others as well. So hopefully that will help you. And with that, I'll end up. I've tried to leave some time for questions and answers. I know I went pretty fast, but I hope that gives you a base set of information that can be of benefit to those you love.
Okay, thanks. And could you please go over some of the seizure signs which are not typical?
Right. So some of the seizures, again, what I focused on was seizures at nighttime. Obviously, seizures during the daytime, a grand mal, tonic-clonic, shaking. I'm not sure if people can see me or not. I'm not shaking. The tonic-clonic area where they're shaking, their eyes roll, they can defecate, they can void. This is all unconscious. They can shake, they can bite their lips, they can choke, they can froth at the mouth. All these are textbook, but they may not happen in the one you care for. So one thing I want to make sure you're aware of is, while that may be obvious, staring kind of off in the space, that kind of thing can be something reflective of absence seizures. The ones I brought up specifically were seizures at nighttime, where you might not, you don't necessarily watch your child or your loved one sleep for hours. You other things you have to do, like sleep yourself, right? So one of the things that can happen is a very suspicious sign. Let me focus it on this is if somebody starts jerking, their extremities or any part of their body starts jerking as they're waking up from sleep, okay, that's a very concerning sign. Okay, your body may jerk, you may twitch, you understand what I'm saying, as you go to sleep. That's not the same. That's probably okay. But if you're waking up, this is something that needs to be looked at, because that can actually be a sign of seizure as well. And the regression in language, the cognitive regression, these all can be loss of language is a sign of seizures as well. I hope that makes some sense, because if it's trying to find seizures at night is very difficult. That's my point. Those are the more subtle ones. I can't hear you.
Sorry, just drawing your attention again to the chat where I put the links to both the English and the Spanish evaluations. And
Okay.
could you repeat what you said about checking iron? The comment about even if the blood result is normal, they should be supplemented with iron.
Yeah, so I'm going to ask people not to trust me. Go on your own after this thing is over and put in ferritin, 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 and put it under 30. Say ferritin less than 30 into ChatGPT or Google or whatever I don't care. Ferritin less than 30, and then put in the word iron deficiency. And you'll be surprised to find that the vast majority of studies now document without any doubt that if you have that kind of level, even if the range of ferritin on your lab, I don't care what lab you use, it's irrelevant to me, is it says it's okay to have a ferritin down to like 14. And there is a lab that says that. I'm not going to talk about that right now. That's unacceptable. So the higher the iron, the more cognition, the better sleep. The better sleep is a function of a lot of things. So I'm not going to oversimplify this to the point of just being, pompously simple. One is if your iron is low, your ferritin is low, which is the best indicator of long-term iron storage, you need to support that. And typically in my patients, I'm just saying this for me, I ask for ferritins minimally above 50, minimally. I'm also part of the Stanford integrative medicine group. We typically want 75s for ferritin in our children and 100s for adults. Women, I get it. It's hard. I understand why, and so do you. But I'm telling you that the right kind of iron can be taken. I typically use the kind that's absorbable. I give it with vitamin C. I'm hoping this is not lost on people, but vitamin C with iron will absorb it quicker. You do not take the kind that hurts your stomach. Women know about this because when that time of the month comes and they get dizzy because they're losing so much blood, they either get dizzy or they vomit if they have to take their iron. And that's a terrible dilemma for a woman to be in. So what I do is I tell my mothers for their female patients and their kids too, the boys who aren't going to have that issue, use the right kind of iron, take it with vitamin C, take it with meals, even though it'll leach a little out, and let's go up the ladder slowly. But that will help sleep, it will help cognition. Most of your neurotransmitters for focus and attention, hear me on this one, folks, are iron dependent. They require iron for synthesis. Dopamine, norepinephrine, epinephrine. This is what is the right kind of iron? The right kind of iron, well, there are different kinds. There's iron ferrous bisglycinate, ferrous chelate, usually heme iron is a good kind. I do not recommend a lot of red meat for different reasons, but a little bit here and there is probably okay. But I typically recommend ferrous bisglycinate or chelates. Chelated iron is the best kind. Elemental iron on its own is very hard to take. I'm
Okay.
sorry, I rushed that one. But
That's okay. Um, what causes a change in personality disorder? If you can tackle that one.
well, that's a great question, but here's the issue. It's multifaceted, right? I wish I had an answer, but probably you have. The first thing is I'm an MD. I'm not a PhD, so I don't have the expertise from a psychological, vantage point. But I'll try to keep this limited. One is the first thing that always has to happen is you need to be able to rule out, excuse me, organic medical causes or contributions. The word cause is kind of a cuss word in medicine. What I'm trying to say is life is more difficult than a cause. Typically, with a lot of these conditions, it's a multiple number of contributions, tributaries. It could be intestinal overgrowth. It could be distress. It could be inflammation. It could be levels of what we call immune activation going on. And that's what we see often with these conditions like PANS and PANDAS. They have what we call flares, if that makes any sense. So I know it's a little different than a personality issue, but I'm telling you that, and without any disrespect to psychology, I want you to understand that at the end of the day, these are just terms we're giving people. At the end of the day, we want to know what is behind this, if possible. And even if we can't cure the whole thing, cure is another four-letter word I don't use a lot, but if we can offer gain, we can offer help, we can help. I've not met an adult or a child yet who won't take a little bit of improvement. So those are some of the things I look for. Infections, allergies. During allergy season, I hope this resonates with some people. People tend to do poorly. People will deteriorate. Behavior goes down. And this is not a mistake. This is not like, oh, I must be losing my mind. No, you're not. This has to do with the activation of the immune system that I've observed in the past 25 years that have to do with external allergens coming in and inflaming the system, mast cells. It's a whole different topic. Mast cell activation. So we can talk. There are some simple things you can do, natural things, not even drugs, that you can give your child or your adult and help them calm some of this down so the personality is mitigated issue.
Okay. A couple of questions about constipation. How do we treat constipation?
I love this question. My children don't like me because I always talk about poop. And that's usually at parties. That's so none of you will want to invite me to your party. I'm just being upfront with all of you. So one is I want you to know I'm very, 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 very strong on making sure that the intestinal health of my patients is supported. And if any of you are my patients on here, you'll know I keep going after this. I want poop charts. So one, I insist on a stool chart for anybody who comes in with even a hint of issues of irregularity, stool retention, discomfort. Until proven otherwise, I know this is bad. You're innocent until proven guilty. In my book, the intestine is guilty until proven innocent. So I typically ask for a poop chart. I ask for a consistency using the Bristol stool scale. I look for regularity, time of day, how much, blood, mucus, or any agents given. Those are some of the metrics I follow, right? Then I go right into it. I have that in my background. Then I go into things like, I know this sounds insanely ridiculous, prunes, prune juice, fiber, whole fiber, things like partially hydrolyzed guar gum, some of these kind of prebiotics. I give probiotics as well. So all these different things. There's prebiotic, probiotic, postbiotic. I give all three depending on the patient. I give that plus a high fiber meal. I give it with fermented foods. I don't know if any of you cook fermented foods. All my Indian patients go, I have fermented food. I eat dosa. I said, look, I know about dosa now. Dosa is cooked. So is idli, if any of you are Indian. So that does not count because anytime you put something in an oven, it kills bacteria. We want the bacteria. So I do that. Secondly, I monitor them as we go. I will then often add other things like stool softeners, or I'll add things like I have herbs that I use for something called pooper. So I'm not like to use brands here. I use pooper, things like, chrysanthemum, these sort of things, as well as tinctures. And then I go from there. But I go all the way down, and then I go from a maintenance phase into clean out phase. So for those of you who ask this question, you have to make sure your maintenance phase, you have a very, very, very low level threshold suspicion if something goes wrong. You don't want to be like, oh, I think it's okay. I think it's okay. Oh, he hasn't pooped for a week. Don't do that. If they don't poop a day, I don't like it. That's how I am personally. So at that point, by 4 p.m., I start invoking some of the things I've talked to you about. Hope that makes sense.
Okay. How about supplements in general that you might recommend for autistic individuals?
Well, that's another open-ended question. I recommend a lot of supplements. There's not one that fits any one person. I will say that some supplements, one, I use mitochondrial supplements. One, so that's a cocktail of vitamins, B vitamins, A, D, C, E, minerals, and antioxidants. I use a mitochondrial cocktail for my patients. On top of that, I use probiotics, vitamin C, extra zinc. All right. I also use broccoli sprout extract with myrosinase enzyme, shown by the study at UMass years ago by Singh to work pretty well. It's a NRF2 activator. For those of you who know what NRF2 is, excellent. Some of these other NRF2 activators are really, really good, and I would strongly recommend some of these for anti-inflammatory measure. Something called I think it's was a black seed extract or black seed oil rather, that actually can help. One of my mothers had that, helped her child. So those are some of the things I start with, and then I go from there after testing. Hope that makes sense. I test my patients because I don't want mothers get very tired of being told give this as item number 43. They don't want that, and neither do the patients. Okay, we have to eat real food. So what I do is I try to test them and take away the things they really don't need. If they don't need it, I don't give it if we don't really have to. We can always optimize, but those are the criteria I use, Lisa.
Okay, wonderful. I'm going to direct everybody to those evaluations. Once again, I know I told you I get annoying about it, but that allows us to keep bringing these quality presentations to you. Um, Clock on the screen says we don't have too much time left. A couple of people are asking if you take insurance, so we might as well get right there.
Yeah. So the answer to that is yes and no. What I mean by that is I'm in the San Francisco area. So there are a lot of big companies like, well, you can imagine who the big companies are. I don't need to tell you. So if someone's employed by some of these companies, the way it works, I'm not a tech guy and I'm not a business guy. So I'm just giving you the best I know. If it's inaccurate, forgive me. These companies cover their patients pretty well, so I charge up front and they get reimbursed by their insurance, or insurance reimburses them. So I charge up front because insurance, I don't want to have to pay extra staff to for insurance. So I charge about half of what some of my doctor colleagues do outside where I live, because they're paying staff to process insurance. I'd rather have you do that. I'm sorry. But it's worth saving you thousands of dollars a year if you come to me. So you can put a little bit extra effort. I know it's work into submitting, but that's how I do it.
Okay, thank you. And you will be getting these slides tomorrow, so you'll have um, Dr. Traver's email. I think that's the best way to get an appointment with you. A
Yeah,
couple of people are asking about that as well.
and if I cannot take care, I'm not deluded. There are people who need different things, but I will always try to help somebody. You Everyone deserves help. Everyone deserves some hope. Okay. And I think it's important to try to be able to offer references. One thing I got taught in college is you go to somebody who they may not know the answer, but they can tell you who to go to get the answer. So that's what we do with this whole domain. I keep referring till we get the answers we need, even if it's not the direct person I know.
Okay. And this might be a good thing to end on because it is a question that I got a couple of times here. And someone says it's becoming very fashionable that children with autism are removed from gluten, starch, sugars, milk, etc., to see changes in their diet. Is this something that you have seen works, doesn't work?
Okay. Okay.
Comment?
Okay. I don't want to go over your time. I'll try to be as brief as possible. This is a huge issue. One, after 26 years, okay, I cannot tell you who a gluten-free, casein-free diet will help and who will not help. Two, it will help certain people categorically. Three, there is not one test that is absolutely like a pregnancy test, the plus minus thing women look at. There's no such thing. I run all the tests. Nothing is that certain, but it can give you clues. Okay. Four, gluten and casein free have the unique ability. This is not something good, but you might want to remember this, to cross react with neural tissue in the brain. And this is not a good thing because what it does is it can create molecular mimicry to cross react on an antibody antigen basis. And you don't really want that. As a result of that, some of these individuals their behavior, but someone asked that question, can change. It can pivot. And when you take it away, their behavior can change as well. And so will their stooling, for that matter, in many cases. Five, especially with casein, and I'm going, forgive me, at least I just as quickly as I can.
That's okay.
I want you to know that the work, some of you probably on here saw the CBS News 6 months ago across the United States, where the boy started talking more when he was given leucovorin. So this is an example of, what do you want, a cutting edge translational therapy. This is what I do, among other things. But this is a prescription now. It's vitamin B9. I know that sounds absurd. Vitamin B9. Folic acid is a form of vitamin B9. But what's wrong with folic acid? A lot of you women already know this in your prenatal vitamins. Folic acid does not come as a natural element. Folic acid is made on machines, okay? Mother Nature does not make folic acid. Mother Nature makes folates. So if a woman has an enzyme that is defective in her own body of being able to translate the folic acid into the kind that's needed to make neurotransmitters and to finish the development of the body of the embryo, that might be an issue, right? So leucovorin is an example of a reduced folate that has been found at high doses, way above what a woman takes in a prenatal. Just we won't go into that right now, to actually help my patients included, change. They get better. The verbal expression is supported. I'm not going to say they recite the Gettysburg Address. Let's not be that insulting. But it does help them. It also can help with cognitive issues and overall social response, SRS scores. So I'm asking my attendees, please look at leucovorin, LEUCOVRIN. Talk to your doctor about it. Your child can get tested using something called the folate receptor antibody test, FRAT, like a fraternity, a frat. You get that done, and then you can see if your child has one of two bad antibodies attacking their brain. And if they do, you get that leucovorin going as soon as you can. And then
Okay.
you stay away from dairy, cow, goat, camel, and bison. I am not joking. Camel, goat, bison, and cow.
Camel, goat, cow, camel, goat, cow, and bison. Okay.
All right.
Those are 4 words to end with if I ever heard any. Thank you so much. You're getting lots of love, lots of thumbs up, lots of hearts. Everyone says we should have more doctors like you. So we thank you very much. We appreciate your time and your effort and your passion, which is so evident. Look at all those hearts. We thank everyone for coming. And of course, we thank Beatrice for tackling the interpretation of this one, which could not have been easy. So
Gracias,
thank you
Beatrice.
so much. And we will see you next week for a parent's perspective about transition to adulthood. Excuse me. And I'll be announcing more about the California Caregivers Conference that PHP has collaborated with the ARC of California. That will be on October 7th, 8th, and 9th. And there's information on that coming to you tomorrow as well. So thank you. Any last words, Dr. David?
I want to give commendation out to every family member here. I wish I could do more. Um, I feel the pain, and it's not professional to talk about pain all the time, but I think it's also remiss to not mention it. I wish that I could do more, and I wish we had more doctors. I never feel adequate, and I don't know if there is an adequate, but I think that all of your loved ones or those you care for, you are their best friend, and they are in the best hands with you. Um, uh, you're never going to give up because you love the person you love, and there are more out there that are on your side, believe it or not. Don't be intimidated to go out and look for them. They're out there. But I want to say thank you to PHP and to Connections California. It's been a privilege to be here, and I hope that I'm happy to do this again in any capacity. It would be a privilege.
All right. Well, thank you. We're going to take you up on that. We all heard it. Okay. All right. Thanks again. And thanks to Kimmy too. Take care, everybody.
Thank-
Have a good night. Bye-bye.